So just like usual, what we're going to do is review the anatomy of the shoulder joint. We'll talk about the conditions and then how to examine that. So the shoulder is primarily a ball and socket joint. Can you go up to the library and get there's two shoulder models? One has muscles, one has only bone. So we just could go through it. And so it's the most mobile joint of the body, and because of that, because of the mobility, also comes instability. So it's the most commonly dislocated joint as well. And the way that it gets its stability is coming from muscles and ligaments. We'll talk a lot about the rotator cuff. That's what's the primary thing that it does, is it holds it in for stability. And then also you can have pain that's in the shoulder, a lot of times is referred from the neck or even from other internal organs and things like that. So we'll talk about the inert tissues. Now in the scapula, has anybody heard about, we've talked before about planes, and there's some that are different than the standard sagittal coronal. And has anybody heard of this plane of the scapula? Okay. So you can see here, this is looking straight down, and you can see that it's 30 degrees forward from the frontal plane. Okay? Because your shoulder blade, sits at this angle right here. So when you're talking about elevation of the arm in the plane of the scapula, that would be this motion here. Okay, and that's going to become important when we talk about examining the shoulder. And then also the counterpart of that, we'll talk about that in a minute, is the plane of the glenohumeral joint, which is here. So that's going to be perpendicular to that. So the actual plane of the actual fossa that the humerus sits in is in this plane. And when you're moving your arms, like if you're running or walking, you don't go like this. Right? It goes in that plane of the joint, the glenohumeral joint. So when you're going like this, that's that actual plane which is perpendicular to the plane of the scapula. So in the actual glenohumeral joint, there's a little bit of stability that's added to that by the labrum, which is a little ring of cartilage that adds to that fossa. Adds a little bit more to the ball and socket. So between the glenohumeral joint, you obviously have the cartilage on the humerus, and then you have cartilage on the glenohumeral surface.
What's the labrum? What is it?
It's a ring of cartilage that goes around. You have the flat fossa like this, and it's a ring of cartilage that goes around it. You'll see some other pictures when we talk about labrum tear. There'll be some more stuff on it. But basically, it's going to be sitting right here. It's a little ring that goes around it to make it a little bit deeper of a dish. And so then a loose pack position is going to be 55 degrees of abduction and 30 degrees of horizontal abduction. And again, like I said, when we're talking about loose pack position, a lot of times it's a position that the joint's in a normal relaxed position. If you look at everybody right now, most of the people are going to be right around there until everybody moves. But right here, okay, this is your loose pack position for the shoulder, okay, where it's most mobile. And then the closed pack is going to be up like this. You can feel there where when you do that, your shoulder starts to get tight. The ligaments are getting all wound up. The joint surfaces are maximum compactness. So this is the labrum right here. Okay. You can see how it just adds a little bit more of a ring around it. And then also that picture in the upper right. This just adds a little bit more stability to the joint. joints, there's different joints that we're going to talk about in the shoulder. Okay? There's going to be primary that are actual real bone-on-bone synovial joints, which are going to be the glenohumeral, the acromioclavicular, and the sternoclavicular. But then you talk about other functional joints, and this is one that will be important when we talk about the conditions. You have what's called the suprahumeral joint, or it's also called the subacromial space or the supraspinatus outlet. So it's not really a true synovial joint, it's more of a functional joint. Okay, so all this, we're on the notes on page 54. So basically what it is a space between the humeral head, right here, and the coracoacromial arch. So what the coracoacromial arch is the coracoid process, the coracoacromial ligament that goes across there, and then the acromion process. So it's going to be I'm going to have to use this because I can't find my pointer. So it's going to be this right up here. And you'll see what this is going to become significant later. So it's right here. Okay, so then we're going to be talking about things that get impinged in that space. Okay, there's going to be bursa, there's going to be tendons. We'll talk a lot about that. And then the space, that space is going to be compromised or decreased when you raise the arm up like that. And then also internal rotation, because you have the greater tuberosity as you internally rotate, that brings that greater tuberosity into that space. So then, as I mentioned, then the other functional joints, or the true joints, are going to be the acromioclavicular and the sternoclavicular. There he is, right on key. So, if the clavicle was here, then that would be the acromioclavicular joint right there. Okay? And then at the other end, then you have the sternoclavicular. Right? So those are the other true joints. And then the sternoclavicular, there's a cartilage disc. And then we come to another functional joint, which is the scapulothoracic. So what that is right here where the scapula meets up with the rib cage. Okay, so is there any cartilage lining those joint surfaces? No. Basically, it's the muscles on the front part of the scapula where they sit along the rib cage. And as your scapula moves, it follows the contours of the rib cage. Okay? So when this is moving like this, the ribs are here. So it's going to go like that. It doesn't just go straight forward or straight back. It follows the curve of the ribs. Because there's a lot of muscles that anchor the scapula in place, and that sets the stage for the stability of the shoulder to move. The scapula has to be stabilized to get shoulder motion, and then also the scapula moves as well. So when we're talking about range of motion, we talk about the scapulohumeral rhythm. So what that is that when the shoulder moves, you only get so much motion right here from the glenohumeral. To get full abduction of the shoulder, the scapula is going to move like that. And it's at a ratio of 2. For every 2 degrees here, you get 1 degree here. Okay, so you move twice as much at the glenohumeral as it does at the scapulothoracic. So when you're observing someone's looking at their shoulder range of motion, if somebody maxes out at their glenohumeral, then they're going to try to raise their shoulder like this. So when you're looking from the back and you watch the shoulder, the scapula's got to move to get full shoulder range of motion.